Hello, I'm Sarina Schrager. I'm a professor of family medicine at the University of Wisconsin Department of Family Medicine and Community Health. Today I'm going to talk about endometriosis. We see a lot of people with endometriosis in primary care, and there is a lot that we can do to help diagnose and manage endometriosis before referring people to a specialist. Learning objectives today, we're going to distinguish characteristics of endometriosis and talk about developing a treatment plan for individuals with suspected endometriosis. But first, what is endometriosis? It's defined as the presence of endometrial cells outside of the uterus. There are still a lot of different theories about what causes endometriosis. One of the most common is retrograde menstruation, meaning that after the menstrual lining, after the endometrial lining is shed, instead of being extruded through the cervix into the vagina, some of those cells actually go backwards through the fallopian tubes and into the peritoneal cavity. There are some thoughts that maybe some changes in embryonic development cause endometriosis. Some people think that scarring from pelvic surgeries will precipitate some development of endometriosis. And then there's some element of immune dysfunction that, as we'll talk about later, contributes to some of the instances of infertility in people with endometriosis. Most of the common sites for implants, so the implants of endometrial cells outside of the uterus, are in the pelvis, but there have been case reports of distant implants as far as the lungs or even in the brain. Endometriosis is actually really common. 3 to 15% of the general population of people born with a uterus, about average of about 10%. In the infertility population, you'll find 25 to 50% of people have endometriosis. And the mean age at diagnosis is between 25 and 30. Symptoms of endometriosis, the main one is pelvic pain, and sometimes this is hard to distinguish between the very common incidence of dysmenorrhea because endometriosis is a little more severe and often doesn't respond to general treatments of dysmenorrhea like NSAIDs or combined oral contraceptive pills. The longer people have endometriosis and endometrial implants, it can also then cause pain with intercourse, ultimately with chronic non-cyclic pelvic pain. Normally people have pelvic pain that comes before their periods, but ultimately after having endometriosis for quite a while, it can lead to chronic pain. Like I said, many people with infertility have endometriosis, and this can be caused by a couple of different components. The first is the physical scarring. Having endometrial implants can cause scarring, and you can actually have physical blockage of the tubes that would impair the eggs from getting into the uterus. Then there's also some inflammation from these endometrial implants that can cause infertility. Diagnosing endometriosis, as I alluded to before, can be somewhat challenging. Usually one of the key components is a description of dysmenorrhea that's more severe than what we call like a garden variety dysmenorrhea. So people talking about missing school or work every month with their periods, not responding to first-line treatments. Sometimes you can see large endometrial implants on ultrasound, or certainly you can see more on an MRI. This is getting better as ultrasound and MRI technology improves. Ultimately, this is one of the conditions where we will try a lot of things before doing the diagnostic standard, which is a laparoscopy. So a lot of people will try a GnRH analog, and I'll talk a little bit more about that later. If it works, that is a sign that maybe somebody does have endometriosis. there are actually challenges with diagnosis, and some studies are fairly striking. And this one study of 7,000 people found that almost two-thirds were misdiagnosed as having just dysmenorrhea. And almost half saw more than 5 different providers in order to get a diagnosis of endometriosis. The average time from symptom onset to diagnosis and treatment is between 7 and 11 years. There aren't a lot of good prospective longitudinal studies on this, but the thought is if you can diagnose endometriosis earlier and have people start adequate treatment, you will prevent the longer term consequences like chronic pain and infertility. So ultimately, laparoscopy, which is a surgical procedure, is going to be your gold standard of diagnosis. And there are a lot of pros to this. You can get a definitive diagnosis by actually seeing what's happening in the pelvis. And also you can treat some of the lesions. There's some good studies showing that treating endometrial lesions actually can improve infertility. The cons are pretty obvious, right? It's an invasive procedure. There's a risk of complications. It's expensive. There sometimes are microscopic lesions that you can't see during a laparoscopy, and the accuracy of the diagnosis can depend on the skill of the surgeon. It also doesn't account for the inflammation and other systemic nature of the disease. So you only see what you see, and those are the things that you can use to diagnose endometriosis. Making decisions about treatment really involves shared decision making. And one of the biggest points of the decision is whether somebody wants to get pregnant right now or whether they don't want to get pregnant and contraception would be appropriate for them. Also, conversations about pain control and long-term goals. Mostly long-term goals related to pregnancy. So if somebody's finished having children or they don't want to have children, those conversations about treatment are a little bit different. First-line treatment for endometriosis is similar to first-line treatment for any cause of dysmenorrhea. Cyclic NSAIDs, so scheduled ibuprofen, naproxen, any other NSAID of your choice, starting a few days before your period, continuing through the cycle. Then the next sort of big category is suppression of ovulation. And there are a couple of different ways of doing this. Very commonly, people take combined oral contraceptive pills. That works very well. Depomedroxyprogesterone acetate also works very well. And then some other progestin methods. GnRH analogs and GnRH antagonists are also 2 common treatments, and I'll talk about that in a minute. And then ultimately, if nothing is working, referral to a gynecologist. So GnRH analogs have been around for a long time, analogs or agonists. So this means these compounds connect to the GnRH receptor. They initially upregulate, but ultimately downregulate your GnRH receptors, which causes really a medical menopause. It suppresses ovulation because you are essentially in menopause. Because of that, people have a lot of side effects, and so you will do an add-back hormone therapy. So you're taking the Lupron, which is really the only GnRH analog available and used commonly in the US, which is an injection. And then you're also taking low-dose estrogen to mitigate some of the menopause symptoms. Most commonly, the use is limited to 6 to 12 months due to side effects and potential for bone loss that you would see normally with menopause. Like I said, Lupron is an injection every 1 to 3 months. Relatively newly approved GnRH antagonist, which also just connects to the GnRH receptor and sort of down regulates the GnRH receptor. So there are a couple differences between a GnRH antagonist, right now marketed as elagolix, It doesn't reliably suppress ovulation because it's not completely turning off the GnRH receptors. It's just sort of slowly decreasing them. You still need contraception because, again, it's not putting you into medical menopause. There is no hormone supplementation needed. It hasn't been around for a long time, so we don't really know how it affects your bones. And this is a pill that you take every day. So where a lot of times Lupron, people will end up at the specialist, the antagonist is commonly prescribed in primary care. So this algorithm is just an easy way to sort of make your way through the diagnostic and management of people with endometriosis. So if the history suggests possible endometriosis, you can consider imaging, an ultrasound or an MRI. And the imaging is you might be able to see something, but you're also ruling out anything else that's causing the symptoms. Discussion of goals of treatment. Do we want to just manage pain versus do we want to get pregnant? Trial the first line treatments that we talked about, NSAIDs, combined oral contraceptives, Depo, progestin IUD, GnRH antagonists. This is all things we can do in primary care. If the person responds to therapy, great, continue with treatment. Revisit the discussion of therapy goals annually, and if treatment starts to fail, then to circle back to try a different treatment. If the person does not respond to initial therapy, that is a time when you would refer them to a gynecologist for a trial of a GnRH analog versus going to laparoscopy for definitive diagnosis. Thank you very much.